This is a short video showing what can be achieved with sharp excision. This lady, she comes from the Indian subcontinent. About 35 years ago, walking barefoot in a village, she stood on a thorn, and ever since then has had a very nasty hyperkeratotic lesion that has resisted all forms of conservative therapy. So she's come through to me to see if I can do anything, and the first video is just a short workup, and then I'll show you what we did with it. I'll start that again. This lady's presented today with a new lesion. You can see she's got quite a corn around there, and this has been present for 35 years since an injury standing on a thorn. But when I actually palpate... Here's a close-up of the lesion. As you can see, a really rather impressive hyperkeratotic lesion. Came on through trauma, so it's a whole other lecture talking about corns up and around the metatarsophalangeal joints where patients are walking. Quite often I need to consider some bony work. It's not just a case of simply seeing a corn and cutting it out and expecting it to do well, but because this one is traumatic in origin, it should do well with simple excision. And then we had a conversation about the different options in terms of simple excision or 3-to-1 ellipse or a flap, but we're going to go for curettage in this particular case. So first thing I'm going to do, give your foot a little bit of a clean, Baljinder, okay? So this is some really nice alcohol prep, makes it nice and clean. So here's the anaesthesia going in. I've gone for field block, and you can see, ouch, she's not entirely like that first scratch of the needle. That's a 25 gauge orange needle. I've gone for a direct infiltration for a couple of reasons. First off, it's a quicker onset anaesthesia, so that's sometimes an advantage in clinic. Second, sometimes more difficult with an ankle block to get that area numb. There's some deep and superficial nerves in it. It doesn't always lend itself to a very effective ankle block. I've had a few failures in that area, so a field block is more effective. The third is by, and perhaps really the most relevant, by raising that lesion under a bleb of anaesthesia, it really reduces the local vascularity. It almost creates really a little bit like an internal tourniquet, reduces the amount of bleeding. This is a technique taught to me by one of my colleagues in Ilkeston, Tim Kilmartin, and he uses this technique. He does a lot, and you'll see some of his writings on this particular technique. So it raises it on a bleb of anaesthesia, so reduces the intra-op bleeding. So that's my main reason for doing this. How are you doing, Baljinder? You okay?
Yeah.
Now.
Yeah, don't watch what he's doing.
Any sharpness around?
You'll feel him touching you, but it won't be sharp.
Any sharpness around there, Chucky? Okay, tiny little bit left there. So I didn't manage to get the most medial aspect of the lesion completely numb, so in truth I did put in a little small rescue block, so there'll be a short break in the video coming up. I've done that before. So I always like to critique my own work, and I think reflective practice is the thing we should do. When I've closed in on this video and I've zoomed in a little bit, you can see there's still a little bit of scar tissue on that anterior distal edge. So I maybe could have been a little bit wider with that excision shape. So I'm just checking now that all the hyperkeratotic lesion has gone. You can see there's very little bleeding. I'm checking that the margins are nice and smooth as well, and I'm looking to see how I can close it. Normally we wouldn't close a circular defect with straight sutures. Normally you'd want to turn that into an ellipse, but because it's a fairly small lesion and there's quite a bit of pliability in the tissue, I'm just pushing the typical suture rules 101. I'm just going to go for a straight prolene across this. ordinarily closing of a circular defect is a whole other lecture, and you wouldn't normally try and get away with it with a straight suture. It'd be better as an ellipse or as a slight flap. But this one rotated quite well. The downside, of course, with taking an ellipse is you're taking away more normal skin, you get a bigger scar, and there's a bigger chance of, a post-procedure disappointment. So just throwing in a suture there, that's a little over and over stitch, quite a strong stitch because it's a plantar wound obviously, and we're going to leave those in 2-3 weeks.
Do you like about Christmas?
Do you think?
Well,
How are you doing? How are you
All
doing?
right.
You're all right,
I can't do anything while you've got hold of my arm. You alright?
Dad will do this. Thank you, Dad.
You're entirely welcome, Chucky Egg. You're entirely welcome.
You gonna want more blue swap? Or are you gonna
No,
have
that's
one?
it. The blues and whites are the con. Thick dressing applied, typically some non-stick and some gauze and a crepe. That will be in place for 2 weeks with painkillers PRN. Here's a close-up of the lesion. You can see it's really quite deep, quite a bit of epidermal thickening and then quite a bit of scar tissue from the original trauma. Very often I'll send these off to histo, and if I'm sending corns, about a third of these will come back as verrucous in origin. In this particular case I didn't, because we knew this was entirely traumatic in origin, but I'm a big fan of histo. 2 weeks later, so stitches I'd leave in for 2-3 weeks, but they came out at 2 weeks in this case, and she was doing really well at 2 weeks. She was a little sore for that first few days. And then at 8 weeks, so this was literally yesterday, she's now 90% lesion free and really pleased.